Hi, I was walking by your room and I noticed you looked uncomfortable. How can I help you?
How can you help me? You can get somebody in here. I've been waiting here
I
45
can find
minutes.
out who your primary provider is. Why don't you have a seat and wait?
I don't want to sit down. Just go. Yeah, go find them. Go. Oh, maybe better yet, tell them I'm leaving. Tell them
okay.
I've been waiting long enough.
There are
I am
rules
out of here.
against leaving the emergency department without talking with them, so I can find
I'll tell
out
you
where
what,
they are
you
right
tell
now.
them I'm leaving.
Don't
then.
yell at me.
Don't
Why
tell
don't
me
you
not to
have
yell.
a seat?
I'm waiting here 45 minutes.
If you don't have a seat, I'm going to need to call security.
Call security.
Please have a
I won't
seat
be here
now.
when you get back. Get out of here. Get out of here. Get out of here. I don't care.
All healthcare providers will encounter agitated patients. It's part of our profession in which we have the privilege to work with people who are sick, scared, and in crisis. In this video series, we will learn how to work with agitated patients and teach you the basic techniques of verbal de-escalation.
I'm Dr. Simpson.
And I'm Dr. Rylander. We're psychiatrists at Denver Health Medical Center and on faculty at the University of Colorado School of Medicine.
At the beginning of this video, you saw a patient encounter that didn't go well. This provider wanted to help but ended up in a situation that was scary and unsafe. We're going to teach you how to handle these situations more effectively.
The approaches that we'll demonstrate in this series are based on guidelines from emergency psychiatry. However, these skills are useful in any patient care setting.
As you watch these videos, you'll learn the key principles of verbal de-escalation. We will start with ways to identify and perform an initial assessment of the agitated patient. Next, we'll learn some basic skills of verbal de-escalation and watch vignettes that demonstrate these techniques. We will then build on this knowledge by teaching some more complex scenarios that include managing teams and encountering armed patients. Finally, we will review some personal safety and escape skills for healthcare providers. We'll begin with identification and assessment of the agitated patient.
In this first chapter, we'll learn to identify the agitated patient, use a standardized scale to assess agitation, and assess the situation for safety.
Agitation is an emergency and requires immediate intervention. What is agitation? Agitation is a state of excessive motor activity associated with a feeling of inner tension. Agitation may occur in any medical setting at any time in the evaluation or treatment process.
Agitation is important to recognize for several reasons. First, the presence of agitation means the patient is in physical or psychological distress. Agitation may also signal the presence of a more serious, life-threatening medical or psychiatric emergency. Finally, agitation may quickly result in injury to the patient or other persons. Let's go back to the first scene and learn more about this initial assessment.
The first element of identifying agitation is recognizing motor hyperactivity. This hyperactivity is often repetitive and purposeless. Examples include pacing, repetitive hand gestures, fidgeting with clothing, and foot tapping. In this scene, the patient was pacing.
When patients are agitated, they become much less attentive to their surroundings. Their range of focus narrows, and they lose their ability to process what is being said. Their thoughts become repetitive and perseverative in nature. Here you see that the patient was not engaging with the provider, but rather repeating the same statements over again.
We recommend the use of a standardized scale to assess the agitated patient. In our service, we use the Behavioral Activity Rating Scale, or BARS. The BARS is a 7-point scale. A BARS of 4 is a normal level of activity. You and I should be a 4 right now. Lower scores suggest lower activity. A 3 means the patient appears sedated. A 2 suggests the patient is asleep but responds normally to verbal or physical contact. A 1 suggests the patient is difficult or unable to arouse. Low scores don't represent agitation, but they do suggest hypoactive behaviors, concerning for other processes including medication side effects or delirium.
BARS scores above 4 represent agitation. A 5 suggests that the patient has signs of overt physical or verbal activity, but they can still follow instructions. A patient at a 6 is extremely or continuously active, and a patient with a 7 is violent. Although the BARS scale suggests a BARS of 7 requires restraints, oftentimes these patients can be de-escalated without coercive interventions. As we rewatch the last lines of the prior video, what score would you give this patient?
You can find out who your primary provider is. Why don't you have a seat and wait?
I don't want to sit down. Just go. Yeah, go find them. Go. Oh, maybe better yet, tell them I'm leaving. Tell them I've been waiting long enough.
There are
I am out
rules
of
against
here.
leaving the emergency department without talking with them, so I can find
I'll tell
out
you
where
what,
they are
you
right
tell
now.
them I'm leaving.
Don't
then.
yell at me. Why
tell me
don't
not
you
to
have
yell.
a
I'm
seat?
waiting here 45 minutes.
If you don't have a seat, I'm going to need to call security.
Call security.
Please
I don't
have
care.
a
I won't
seat
be here
now.
when you get back. Get out of here. Get out of here. Get out of here. I don't care.
The patient does not respond to verbal redirection, suggesting they are more than a 5. This patient is at least a 6 to start, and by the end of this ineffective encounter, the patient is violent and scores a 7.
Let's try another scene. This patient appeared confused on the street, and the police brought him to the emergency department for an evaluation.
It was like the other day or a week ago when
Hi, Norman. My name's Dr. Albert. I'm a
That
psychiatrist.
there was that guy.
How are you doing?
He had a cup. He had
Okay.
a cup and
You're looking a little upset right now.
He
Do you
had
want to
that
sit down
thing.
so we can talk about it?
he had that thing and
Okay.
then
Thanks for sitting down. Tell me a little bit more about what's going
they
on.
put that thing in my way and
How would you score this patient on the bars? This patient is pacing, but responding to verbal directions to sit down. He's not so agitated that he can't attend to a conversation with his provider. He would be scored a 5 on the bars.
Using the bars provides an easy way to communicate the patient's mental status, helps staff feel more comfortable with agitated patients, and helps the unit feel safer.
The most important indicator of impending violence or increasing agitation is the patient's current symptoms and presentation. An evaluation of the patient at this moment in time is more helpful for predicting violence than a history of prior violence, diagnoses, vital signs, or any laboratory workup.
Another crucial part of your assessment is considering your surroundings. Be aware of objects that may be dangerous if thrown or otherwise used as a weapon. Some obstacles may represent a fall hazard or may entangle the patient or other persons. Exits should be readily accessible for both the patient and other persons. Let's consider the surroundings of this latest scenario.
Consider the placement of furniture in the room. Are there objects between you and the patient? Also, where are the exits? Both the clinician and patient should be able to easily exit the room. The first video certainly had objects that were potentially dangerous.
While the bed may prevent the patient from too quickly reaching the clinician, it is also an obstacle for any staff. Beds may be moved or flipped by an agitated patient.
We have reviewed how to identify and assess the severity of agitation, and we've discussed keeping in mind the safety of your surroundings. The final point we need to make now is that agitation is a symptom, not a diagnosis. Agitation may result from delirium caused by many different disease processes, including seizures, infections, metabolic derangements, or medication side effects. Also consider intoxication, withdrawal, or decompensated psychiatric illness in your differential.
The medical evaluation of the agitated patient is beyond the scope of this lesson. For now, remember that agitation is a symptom of a more serious condition and can quickly escalate if not addressed promptly.
Fortunately, you don't need to know why the patient is agitated in order to use verbal de-escalation. In the next chapter, we will begin learning these techniques.